Welcome. In this session, we'll be discussing about retinitis pigmentosa and allied disorders, which belong to the broad category of inherited retinal disorders, and we will start with an overview of inherited retinal disorders. Inherited retinal disorders are characterized by bilateral involvement, and typically they involve the two eyes of an individual symmetrically. Inherited retinal disorders or IRDs can be classified into five major categories. Those with primarily diffuse involvement of the retina, and this group includes retinitis pigmentosa, cone rod dystrophy, cone dystrophy, and Leber congenital amaurosis. This photograph shows a fundus with retinitis pigmentosa, and we'll be discussing this category of entities in this session. Those with primarily diffuse choroidal dystrophies such as choroid edema as seen here in this photograph and gyrate atrophy as seen here in this photograph. Those with primarily macular involvement such as Stargardt's disease as seen here in this photograph and Best's disease as seen here in this photograph. Those classified as vitreoretinal disorders such as Goldman-Fabry syndrome as seen here in this photograph, Stickler syndrome as seen here in this photograph, and X-linked retinoschisis as seen here in this clinical photograph, and those that are stationary or non-progressive disorders such as congenital stationary night blindness and achromatopsia. These two photographs show the Mizio-Nakamura phenomena in Oguchi's variant of congenital stationary night blindness. Evaluation and monitoring of inherited retinal disorders involve diagnostic testing, which includes perimetry, electrophysiology, OCT, fundus autofluorescence, and genetic testing to identify the causative gene. Systemic evaluation is crucial to recognize syndromic IRDs, which we will be discussing, and to exclude acquired conditions which may have a similar clinical presentation and which may be treatable, such as vitamin A deficiency and infectious retinopathies. Examining family members to establish the mode of inheritance is important for genetic counseling, but frequently no family members are found or known to be affected, which may be due to lack of information, variable expressivity or penetrance of the genetic mutation, or if the genetic mutation occurs first in the proband. And genetic testing can identify the affected individuals and carriers in the family. Regular follow-up is required every 1 to 2 years to evaluate the rate of progression and to identify associated treatable conditions such as refractive error, cataract, cystoid macular edema, glaucoma, and retinal exudation. We have to note that most of these entities were originally described based on ophthalmoscopic findings and clinical codes, and the genetic mutations causing these disorders were identified much later, and this has led to the appreciation of the existence of variable expressivity, which means that the same genetic mutation displaying variability in onset, severity, and course of the disease phenotype, variable penetrance, which means a genetic mutation causing a phenotype only in some individuals carrying the mutation but not in other individuals carrying the same mutation. Genetic heterogeneity, that is, mutations in different genes causing the same phenotype, and pleiotropy, which is different mutations in the same gene causing different phenotypes and modes of inheritance. Updated information about genes implicated in IRDs is available on retnet.org website. So we start with retinitis pigmentosa, which refers to a set of hereditary disorders that affect the retina, that is the photoreceptors and the retinal pigment epithelium, diffusely across the entire retina. In retinitis pigmentosa, rod photoreceptors are affected early in the disease process and cones are affected later in the disease course, and so retinitis pigmentosa is also known as rod cone dystrophy, and typically retinitis pigmentosa is a progressive disease. Retinitis pigmentosa can present as non-syndromic or typical retinitis pigmentosa in which only the eye is involved, and syndromic retinitis pigmentosa when ocular manifestations are associated with other systemic manifestations. Histopathological examination, the earliest sign of retinitis pigmentosa is shortening of the outer segments of the rods, and the peripheral rod photoreceptors develop axon-like processes called neurites which extend up to the internal limiting membrane. The shortening of the outer segments of the rods is followed by loss of rod photoreceptors, which is indicated by the reduction in the number of nuclei in the outer nuclear layer as seen here in this photograph, which shows that the outer nuclear layer in an eye with retinitis pigmentosa has fewer number of cells as compared to a normal retina. This loss of rod photoreceptors in retinitis pigmentosa occurs initially in the mid-peripheral retina. Following death of the rod photoreceptors, the retinal pigment epithelial cells get detached from the Bruch's membrane and migrate into the neurosensory retina. And bone spicule pigmentation, which is a characteristic feature of retinitis pigmentosa, represents a cuff of RP cells within the neurosensory retina surrounding a retinal blood vessel, and following migration of the RP cells from their normal position, the underlying choriocapillaris atrophy. Cone photoreceptors undergo similar changes with shortening of the outer segments, elongation of axons, followed by cell death. Involvement of cone photoreceptors in retinitis pigmentosa, which is a predominantly rod photoreceptor disorder, is said to occur because of the following probable reasons: the causative mutation being expressed not only in the rod photoreceptors but also in the cone photoreceptors, collateral damage to the cones during death of the rod photoreceptors, and because of reduction in rod-derived cone viability factor, which is a protein secreted by the rod and is necessary for the survival of the cones. Arteriolar attenuation is another characteristic feature of RP, which is said to occur due to perivascular cuffing by RPE cells, reduced metabolic need of the retina, and hyperoxia-induced vasoconstriction, with hyperoxia occurring due to increased oxygen transmission from the choroid through the thinned outer and inner retina. But in a few RP patients, increased vascular permeability may lead to a Coates-like retinopathy with peripheral retinal telangiectasia and exudative retinopathy, which we will be discussing further. Other histopathological changes of RP include Muller cells undergoing reactive gliosis, reactive hyperplasia of astrocytes, which is said to result in the optic disc pallor and epiretinal membrane formation, both typical of retinitis pigmentosa, and microglial migration to the outer retina and their activation, promoting photoreceptor death and phagocytosis. Worldwide prevalence of typical or non-syndromic RP is said to be 1 in 5,000 individuals, but the prevalence of carrier state of recessive retinitis pigmentosa, either autosomal recessive or X-linked, is said to be 1 in 100 individuals. Typical RP comprises 50% of all inherited retinal disorders. The average age at diagnosis of typical RP is 35 years, but it varies widely with the mode of inheritance, which we will be discussing next, and males are affected slightly more commonly because of the presence of X-linked retinitis pigmentosa. Mode of inheritance reported by most pedigree analysis suggests that autosomal dominant retinitis pigmentosa and autosomal recessive retinitis pigmentosa each contribute to 25% of all retinitis pigmentosa patients. X-linked retinitis pigmentosa contribute to 10% of all retinitis pigmentosa patients, but patients with simplex RP, none of whose family members are known or found to be affected, comprise 40 to 50% of all retinitis pigmentosa patients. And so far as the causative genes are concerned, the 5 genes whose mutations are most frequently associated with RP in order are USH2A, RPGR, EYS, RHO, and RP1, but causative genes remain unknown in 30% of RP patients when considering all modes of inheritance. Mutation in rhodopsin gene accounts for 25% of all autosomal dominant retinitis pigmentosa, and among the other genes whose mutations are implicated in the causation of autosomal dominant retinitis pigmentosa, the more frequent ones are RP1 gene, the PRPH2 gene, and the PRPF genes. Autosomal recessive retinitis pigmentosa is typically earlier in onset and more severe than autosomal dominant retinitis pigmentosa, and one of the genes whose mutation can cause autosomal recessive retinitis pigmentosa is RPE65, for which a treatment is now available, which we'll be discussing later in this session. Most patients with X-linked RP have mutations in RPGR and RP2 genes. Hemizygous males with X-linked RP have early onset severe disease, which is usually more severe than autosomal recessive RP, and this is important to remember. These patients usually develop severe nyctalopia by mid-teens, loss in visual acuity by 20 years of age, and blindness by 40 years of age. Female carriers of X-linked RP have variable but definite involvement, and this is also important to remember. And the involvement in female carriers of X-linked RP include irregular pigmentation with asymmetric involvement of either eye due to random X chromosome inactivation in females, retinal sheen, and ERG abnormalities. Patients with simplex RP, as we have mentioned, do not have any family history, and simplex RP is also known as sporadic or isolated RP. And simplex RP can be due to lack of information, variable penetrance or expressivity, inheriting autosomal recessive genes from carrier parents, or de novo mutations. The two hallmark symptoms of retinitis pigmentosa are nyctalopia or night blindness and constriction of peripheral visual fields. Nyctalopia starts in the first or second decade of life, earlier in X-linked retinitis pigmentosa and autosomal recessive RP as compared to autosomal dominant RP. The patient complains of getting disoriented and becoming accident prone in a dim environment, but in an urban setting with well-lit indoors and outdoors, nyctalopia can become apparent at only a more advanced stage of the disease. Nyctalopia can occur in other diseases also, such as congenital stationary night blindness and high myopia, and along with retinitis pigmentosa, these entities constitute the differential diagnosis of nyctalopia. And patients with uncorrected refractive error and macular dystrophy may also complain of visual difficulties in dim light, but visual difficulties in dim light of these patients can be differentiated from nyctalopia of RP with ERG and dark adaptometry, which we will be discussing further in this session. The other hallmark symptom of retinitis pigmentosa is loss of peripheral visual field, which is typically insidious in onset and slowly progressive, but in advanced disease there can be severe constriction of the peripheral visual field resulting in tunnel vision. In contrast to conventional understanding, visual acuity loss can occur early in typical retinitis pigmentosa when significant peripheral visual field still remains intact, and this can occur due to macular edema, diffuse retinal vascular leakage, epiretinal membrane, and RPE changes. Later, loss in visual acuity occurs due to damage to the cone photoreceptors. Long-term prognosis of visual acuity in RP depends on the mode of inheritance. Patients with autosomal dominant RP are more likely than patients with autosomal recessive RP to retain good visual acuity beyond 60 years of age. As we have mentioned, patients with X-linked RP are usually blind by 40 years of age, but patients with sector RP, which we will be discussing later in this session, retain good visual acuity throughout their life. Other symptoms which can occur in patients with RP include color vision defects, which occur along with decrease of central visual acuity due to loss of cone photoreceptors, and photopsias, which are described as tiny shimmering lights. The classic signs of retinitis pigmentosa are intraretinal bone spicule pigmentations, attenuated blood vessels, particularly the arterioles, optic disc atrophy, and mottling and granularity of retinal pigment epithelium. These three form the classic triad of retinitis pigmentosa. This photograph is of an eye with very advanced retinitis pigmentosa, showing atrophy and bone spicule pigmentation in the macula. In early stage of retinitis pigmentosa, although visual field defects and findings on other diagnostic tests such as fundus autofluorescence as seen here may be present, the ophthalmoscopic appearance of the retina may be almost normal without any pigmentation, and this is called retinitis pigmentosa sine pigmento or paucipigmentary retinitis pigmentosa, and this stage can persist for decades before the more typical signs appear. And some of these eyes with retinitis pigmentosa sine pigmento may demonstrate multiple fine white dots in the mid and far peripheral retina resembling retinitis punctata albescens, which we'll be discussing later in this session. When the bone spicules develop, these white dots become less apparent. So retinitis pigmentosa sine pigmento is considered as an early stage of retinitis pigmentosa and not a separate type of retinitis pigmentosa. The two early signs of retinitis pigmentosa are blood vessel attenuation, particularly that of the arterioles, and mottling and granularity of retinal pigment epithelium, which appears initially in the mid and far periphery of the retina. Atrophy of RP and choriocapillaries in advanced stages of RP can lead to fundus pallor and increased visibility of larger choroidal blood vessels. And as we have mentioned, atrophic lesions can also occur in the macula in advanced RP. Some retinitis pigmentosa patients, even in their advanced stages, show preservation of the retinal pigment epithelium along the arteries, as seen here in this clinical photograph, and the corresponding fundus autofluorescence, and this is called PPRPE. Intraretinal bone spicule pigmentation, as seen here in these two photographs, occur due to cuffing of pigments around blood vessels, most prominently at the branching points of these blood vessels, and this pigmentation is most prominent in the mid-peripheral retina, just peripheral to the arcades, and the pigmentary changes are typically spiculed in appearance in typical retinitis pigmentosa. Other than typical retinitis pigmentosa, the spiculed appearance is found in Usher syndrome among rod cone dystrophies, in cone rod dystrophy, and in acquired conditions such as trauma. But in other inherited and acquired pigmentary retinopathies, the pigmentation is not spiculed in appearance but appears as stippling or clumps. Peripapillary chorioretinal pallor or golden ring sign can be found in the early stages of retinitis pigmentosa, and in the later stages of the disease, the optic nerve head becomes characteristically waxy and pale, as seen here in this clinical photograph, both due to optic atrophy and gliosis over the disc, and the zone of peripapillary chorioretinal pallor is replaced by pigmentary mottling and RPE atrophy. The cup disc ratio is often small, and optic nerve drusen may develop in eyes with retinitis pigmentosa. A metallic sheen, as seen here in this black and white fundus photograph, is occasionally found in female carriers of X-linked RP and rarely in young male patients with early stage X-linked RP, and wrinkling due to epiretinal membrane, as seen here in this photograph, is often found in the macula of eyes with retinitis pigmentosa. Cystoid macular edema can occur in 20% of retinitis pigmentosa patients and may not leak on fluorescent angiography, and this is important to remember. Cystoid macular edema may progress to inner lamellar hole. Coats-like retinopathy, as seen here in this clinical photograph, may occur in 4% of all retinitis pigmentosa patients, but unlike idiopathic Coats disease, Coats-like retinopathy in retinitis pigmentosa can be bilateral, has no sex predilection, and has an onset at an older age. Vitreous cavity of an eye with retinitis pigmentosa can show fine dust-like pigment cells which are said to be released from degenerated retinal pigment epithelium, and primary open-angle glaucoma has been reported in up to 12% of RP patients, but disc and visual field changes of retinitis pigmentosa may make diagnosis of associated glaucoma difficult. Anterior segment associations of retinitis pigmentosa include cataract, particularly posterior subcapsular cataract, which has been found to be most frequent in X-linked RP patients, and keratoconus. And refractive changes found most commonly in eyes with retinitis pigmentosa are high myopia and astigmatism. Perimetry is an important diagnostic test for patients with retinitis pigmentosa to quantify visual field loss and to monitor the rate of deterioration of visual field over time. But we need to understand that conventional tests of perimetry, either automated static or Goldman kinetic perimetry, evaluate cone function. The earliest changes in retinitis pigmentosa are isolated relative scotomas in the mid-periphery between 30 and 50 degrees from fixation, because this is the region of highest rod density, which is the primary target of damage in retinitis pigmentosa, whose destruction also leads to collateral destruction of cones. And since the visual field defects of early retinitis pigmentosa lie between 30 and 50 degrees from fixation. They can be missed in standard 24-2 and 32 automated static threshold perimetry strategies conventionally used for diagnosis of glaucoma. These scotomas enlarge, deepen and coalesce, resulting in a ring scotoma around the central field, leaving central and peripheral, typically temporal, islands of intact visual fields. As the disease progresses, the peripheral islands are usually obliterated before the central islands are affected. Goldman perimetry typically shows a relatively large isopter with a larger target and a significantly diminished isopter with a smaller target in early stage of retinitis pigmentosa in comparison to the separation between these two same isopters in a normal individual, and this increased disparity between these two isopters is typical for retinitis pigmentosa. Later in the disease, the isopter to a larger target also constricts. Superior visual field is affected early and most severely in many types of retinitis pigmentosa, and this is important to remember. And the visual field results are typically bilaterally symmetrical between the two eyes of an individual with retinitis pigmentosa. But as we have mentioned earlier, female carriers of X-linked retinitis pigmentosa can show asymmetrical and irregular visual field defects because of random X chromosome inactivation in females. There is another method of perimetry called two-colored dark adapted visual field testing, or 2C-DAVF, which can isolate responses of rod photoreceptors from responses of the cones. As we have mentioned, standard automated perimetry uses a bright background illumination of 31.5 apostibs, which suppresses rods and evaluates only cone function, but 2C-DAVF uses two colored stimuli, a cyan stimulus and a red stimulus, on a dark background to determine threshold sensitivities at various retinal locations, and rod deficiency relative to cones is suggested by difference in threshold sensitivities between the two stimuli in the same locations within the visual field. Dark adaptometry, which we have discussed in session 14 of this section, demonstrates elevation of thresholds of both rods and cones and prolonged dark adaptation in individuals with retinitis pigmentosa. This dotted line represents the dark adaptation curve with cone threshold and rod threshold from a normal individual, and each of these lines represent dark adaptation curve of retinitis pigmentosa patients with varying severity levels, showing elevation of both the cone thresholds and the rod thresholds and prolonged dark adaptation. We have discussed about electrophysiology in session 13 of this section. Electroretinography responses from eyes with retinitis pigmentosa are similar across genetic types, correlate with visual function and age of the patient, and can be present before ophthalmoscopic signs are detected. And ERG responses from eyes with retinitis pigmentosa show amplitude reductions and implicit time delays, with the rod responses being more severely affected than cone responses, and this is very important to remember. In contrast, in cone rod dystrophies, which we will be discussing later in this session, cone responses are more severely affected than rod responses. In early stage of retinitis pigmentosa, the response to dark adapted dim flash shows a reduced B wave as compared to that from a normal individual, and the response to dark adapted bright flash shows a subnormal A wave as compared to that from a normal individual, and this subnormal A wave is said to be a cone response to the bright flash, and the B wave to A wave ratio is preserved when compared to that from a normal individual. And the 30 Hz flicker response, which is a cone response, is also subnormal and delayed in early stages of retinitis pigmentosa. In advanced to very severe retinitis pigmentosa, there is severe to complete loss of rod photoreceptor function. The responses to dark adapted dim flash and bright flash are severely compromised to undetectable, and the 30 Hz flicker response from the cones is markedly subnormal and delayed. Bertson et al. Estimated the average decrease in residual ERG amplitude to be 16% to 18.5% per year, with the rate of decrease being least in patients with autosomal dominant retinitis pigmentosa. X-linked RP carriers can also show ERG abnormalities, usually as a mild reduction in amplitude and delay in implicit time of B waves. But in pigmented retinopathy due to inflammatory entities, ERG shows reduction in rod and cone amplitudes, but the implicit time remains normal. Multifocal electroretinography and pattern electroretinography show relative preservation of waveforms in the central region as seen here in this multifocal electroretinogram report. And in most cases of retinitis pigmentosa, when electroretinography is abnormal, electrooculography is also abnormal, and so electrooculography is not important as a diagnostic test for retinitis pigmentosa. On fluorescein angiography, transmission hyperfluorescence due to RPE defects are found in early phase of the angiogram, and diffuse leakage at the level of outer blood-retina barrier is found in later phases of the angiogram. Very few patients show leakage from perifoveal retinal capillaries as seen here in this photograph, and as we have already mentioned, cystoid macular edema in retinitis pigmentosa patients may not show any leakage, and this is important to remember. Fluorescein angiography is also useful in retinitis pigmentosa patients with Coats-like retinopathy when laser photocoagulation of the retinal telangiectatic lesions are planned. On fundus autofluorescence, areas of RP atrophy show hypoautofluorescence as seen here in this photograph, and most RP patients demonstrate a pericentral ring of hyperautofluorescence, also called the Refsum holder ring, and this pericentral ring of hyperautofluorescence marks the junction of normal and abnormal retina, and it is said that the wider this pericentral hyperautofluorescent ring, the better the visual prognosis. Optical coherence tomography in eyes with retinitis pigmentosa shows reduction in thickness or absence of the photoreceptor layer outside the central macula where this layer is preserved, and optical coherence tomography can easily pick up cystoid macular edema when it occurs in an eye with retinitis pigmentosa. This color photograph shows a retinitis pigmentosa eye with CME which has been picked up on OCT, and the corresponding fundus autofluorescence image shows zones of hypoautofluorescence corresponding to the CME. And adaptive optics, which we have discussed in session 6 of this section and which can image individual photoreceptors, can demonstrate reduction in density of both rod and cone photoreceptors in an eye with retinitis pigmentosa. Color vision testing with Farnsworth-Moon cell test shows that both protan-doytan, that is red-green, and tritan, that is blue-yellow axis are affected in retinitis pigmentosa, and the tritan axis is preferentially affected in eyes with early foveal cone loss. Typical or non-syndromic retinitis pigmentosa can be classified based on the nature of the genetic defect, the mode of inheritance, the age of onset, or the pattern of retinal involvement. A mutant allele can behave in different ways depending on where the mutation occurs within the gene and the status of the normal allele. We can have loss of function mutations where the mutant allele does not produce the gene product, and a loss of function mutation will have a recessive mode of inheritance if the amount of gene product produced by the normal allele is not sufficient enough to carry on the required function, and alternatively can have a dominant mode of inheritance if the amount of gene product produced by the normal allele is sufficient enough to carry on that function. The mutation can be dominant negative with a dominant mode of inheritance if the gene product from the mutated allele interferes with the function of the gene product from the normal allele. And in a toxic gain of function mutation, which is also dominant in mode of inheritance, the gene product of the mutated allele interferes with the regulation of expression of the normal gene or regulation of cellular biochemical pathways. On the basis of inheritance pattern, typical or non-syndromic RP can be classified as autosomal dominant, autosomal recessive, X-linked, simplex RP, and very rarely mitochondrial. 70% of simplex RP are estimated to be actually due to autosomal recessive mutations. On the basis of age at onset, typical or non-syndromic RP can be classified as having a congenital or childhood onset, which are usually autosomal recessive, as having a juvenile or early adult onset, which represent the most common presentation age group and can have any of the three common inheritance patterns, and as having an adult or late onset, which are mostly autosomal recessive and often go unrecognized clinically. And on the basis of the pattern of retinal involvement, in addition to the classic presentation of retinitis pigmentosa, we may have retinitis pigmentosa sine pigmento, which we have discussed earlier in this session. Pericentral retinitis pigmentosa and sector retinitis pigmentosa. In pericentral retinitis pigmentosa, pigmentary changes and visual field defects occur between 5 and 15 degrees of fixation, that is, pigmentary changes are found within the arcades. And as these visual field defects enlarge, deepen and coalesce, visual acuity gets affected early in pericentral RP. The ERG is subnormal but is usually better preserved in pericentral RP as compared to classic RP. So this pair of wide field images show a case of classic retinitis pigmentosa showing RPE changes and pigment spicules outside the arcades. And this pair of wide field images show a case of pericentral retinitis pigmentosa showing RPE changes and spicules within the arcades. These two photographs show the fundus autofluorescence findings in pericentral RP and classic RP. In pericentral RP, the hypoautofluorescent region is mostly within the arcades, and in classic RP, the hypoautofluorescent region is mostly outside the arcades. Sector retinitis pigmentosa is characterized by involvement of one or two quadrants of the retina, most commonly the inferior quadrants, as seen here in these two photographs from the eyes of a patient with sector retinitis pigmentosa. The affected areas are usually symmetric between the two eyes as shown by these two photographs, and over time typically there is minimal or no extension of the involved retinal area. However, in later stages of the disease, the involved area shows complete regional atrophy of the retina and the underlying retinal pigment epithelium and the choroid. Most patients with sector retinitis pigmentosa are asymptomatic with relatively good visual acuity, and mutations in several genes have been associated with sector retinitis pigmentosa. But many cases of sector retinitis pigmentosa are sporadic or isolated without a family history, and this may be due to somatic mosaicism, that is, mutation occurring in a somatic cell following fertilization. Visual field testing in sector retinitis pigmentosa show visual field defects in corresponding sectors of the visual field, typically the superior visual field corresponding to the inferior retina, which is most commonly involved in sector RP. And electroretinography shows relative preservation of ERG responses with minimal or slow worsening over time. Typically, there is mild or moderate reduction in amplitudes with normal implicit times of A waves and B waves in ERG. ERG can detect or exclude generalized disease in a patient with clinically localized involvement, and this is important to remember. Multifocal ERG responses are reduced only in the affected location, and fundus autofluorescence, as seen here in this photograph, shows a semicircular hyperautofluorescent zone between the fovea and the involved sector. It is important to remember that a sectoral distribution of pigmentary changes can be an early stage of typical retinitis pigmentosa, so enough time needs to be given before a diagnosis of sectoral retinitis pigmentosa is made. Unilateral or asymmetric retinitis pigmentosa is an extremely rare entity, and two possible genetic causes of unilateral or asymmetric retinitis pigmentosa are X chromosome inactivation in female carriers of X-linked retinitis pigmentosa and somatic mosaicism. And vast majority of unilateral pigmentary retinopathy are actually acquired and not retinitis pigmentosa, among which trauma and diffuse unilateral subacute neuroretinitis are important entities to remember. We have discussed about DUSN in the section on uveitis. Syndromic retinitis pigmentosa refers to the association of ocular manifestations of retinitis pigmentosa with systemic disorders in the context of an inherited syndrome, and it is estimated that 20 to 30% of patients with retinal manifestations of retinitis pigmentosa are syndromic. Opinion differs as to what constitutes syndromic retinitis pigmentosa, and some texts consider only Usher's syndrome as syndromic retinitis pigmentosa because, as we have discussed, only Usher syndrome demonstrates bony spicule pigmentation, which is characteristic of retinitis pigmentosa among all rod cone dystrophies. Others include a large number of disorders with varied pigmentary retinopathy, in syndromic retinitis pigmentosa and classifies them into ciliopathies such as Usher syndrome and Bardet-Biedl syndrome, inherited metabolic disorders such as Refsum's disease and neuronal ceroid lipofuscinosis, mitochondrial disorders such as Kearns-Sayre syndrome, and miscellaneous disorders such as cocaine and perching. And we will be discussing only about Usher syndrome, Bardet-Biedl syndrome, neuronal ceroid lipofuscinosis, and Refsum's disease. Usher syndrome is autosomal recessive sensorineural deafness associated with retinopathy having bone spicule pigmentation indistinguishable from typical retinitis pigmentosa. Usher syndrome is the most common among syndromic RP and is estimated to contribute to 50% of deafblind people in US. Type 1 Usher is the most severe, characterized by congenital profound deafness and speech impairment, vestibular symptoms, and childhood onset retinopathy. Type 2 Usher is characterized by congenital but partial deafness, no vestibular symptoms, with later and milder onset retinopathy. Usher type 3 is rare, found in only certain populations, and the proteins coded by the normal genes, which are mutated in Usher syndrome, are associated with the connecting cilium of photoreceptors and the stereocilium and kinocilium of hair cells of the inner ear. There is no Usher 1A, and Usher 1B is caused by mutation in the MYO7A gene, and this is the most severe Usher subtype. Usher 2A, which is caused by mutation in the gene coding usherin, is the most common Usher subtype. ERG is profoundly abnormal to non-recordable in all types of Usher syndrome, and it is important to remember that cochlear implantation is beneficial in congenital profoundly deaf children with Usher syndrome, helping them in speech development. So all congenital profoundly deaf children should be screened for Usher syndrome with ophthalmoscopy, ERG, and genetic testing. Other syndromic retinitis pigmentosa disorders can have hearing abnormalities, but they also have additional systemic manifestations, and this includes Bardet-Biedl syndrome and Refsum's disease, and congenital rubella syndrome, which belongs to the differential diagnosis of retinitis pigmentosa, can also cause hearing loss with pigmented retinal degeneration. Bardet-Biedl syndrome is defined as the presence of either 4 primary features or 3 primary and 2 secondary features. Primary features include retinal degeneration, truncal obesity, post-axial polydactyly, post-axial meaning polydactyly on the ulnar side of foot or hand, hypogonadism or hypogenitalism, renal abnormalities, and mental retardation, which may be mild, and a large number of entities are included in secondary features of Bardet-Biedl syndrome. Mutations in a large number of genes have been identified among patients with Bardet-Biedl syndrome, and most of these are autosomal recessive in nature. Visual acuity is affected early in Bardet-Biedl syndrome because of prominent atrophy of macular RP and choriocapillaries occurring early in Bardet-Biedl syndrome, as seen here in this photograph, and this atrophy can also occur in a bull's eye pattern. ERG in patients with Bardet-Biedl syndrome shows either rod cone loss pattern or cone rod loss pattern or is unrecordable. Neuronal ceroid lipofuscinosis or NCL are a group of inherited neurodegenerative disorder characterized by abnormal storage of lipoproteins and other hydrophobic materials within lysosomes in neurons and other cells, and it is the most common neurodegenerative disorder among children. Most forms of NCL are autosomal recessive. Central vision is affected early, leading to profound visual loss, and ERG is affected early and is usually totally extinguished by 4 to 7 years of age. 13 forms of NCL, each with its specific mutation, has been described, and the 4 classic forms are infantile onset NCL, which manifests by 8 to 24 months of age; late infantile onset NCL, which manifests by 2 to 4 years of age, in which cone ERG responses are affected more severely than rod responses; juvenile onset NCL or Batten-Mayo disease, which manifests by 4 to 8 years of age, in which rod ERG responses are more severely affected than cone responses; and adult onset NCL, in which visual symptoms and findings are absent. Refsum's disease are two very rare autosomal recessive paroxysmal disorders with a prevalence of 1 in 10 million individuals. Infantile Refsum disease is part of Zellweger syndrome and occurs due to a defect in peroxisome biogenesis. It presents in first year of life and serum phytanic acid levels are only moderately elevated in infantile Refsum disease. Ophthalmic features of infantile Refsum disease include poor vision and nystagmus, and retinal examination shows white flecks early in the course of the disease which later disappear and are replaced by coarse pigment clumping. Optic atrophy and cataract also occurs, and ERG is profoundly abnormal early in the disease. Infantile Refsum disease is fatal by second or third decade of life. Adult Refsum disease occurs due to deficiency in a peroxisomal enzyme and presents in early childhood with anosmia, ichthyosis, pigmented retinopathy, and shortened metacarpals and metatarsals, and serum phytanic acid levels are severely elevated in adult Refsum disease. Patients with adult Refsum disease present with night blindness developing by late childhood, followed by peripheral field defects, and pigmented retinopathy develops in the third decade of life. Other ophthalmic features include cataract and poor pupillary dilatation, and ERG responses are severely reduced or non-recordable at all ages. Treatment of adult Refsum disease is restriction of dietary phytanic acid, which is found in dairy products and ruminant fat, and although this measure limits progression or even improve neurologic deficits, visual deficits do not respond. Then we have disorders which, like retinitis pigmentosa, are inherited progressive diffuse retinal dystrophies but do not fall in the retinitis pigmentosa category, and among them we have cone rod dystrophy and cone dystrophy, Leber congenital amaurosis, and retinitis punctata albescens. Cone rod dystrophy and cone dystrophy have a prevalence of 1 in 30,000 individuals, and all three modes of inheritance are known to occur among these group of patients. Most cases of cone rod and cone dystrophy are non-syndromic, with the cone rod or cone dystrophy being the only manifestation of the disease, but ocular and systemic associations of cone rod and cone dystrophy have also been described. Cone rod or cone dystrophy usually present within the first 3 decades of life, and since the cone photoreceptors are primarily involved, these patients complain of hemeralopia, photophobia, loss of visual acuity, and colored vision. Photophobia refers to discomfort in bright environments, and hemeralopia refers to poorer vision in brighter environments as compared to darker environments. Ophthalmoscopic examination may show a normal fundus as seen here in this photograph, or may show macular pigmentation and atrophy and temporal pallor of optic disc as seen here in this photograph. The macular pigmentation and atrophy in cone dystrophy patients typically have a bullseye maculopathy pattern with a ring of RP atrophy surrounding the foveal center, or the macular atrophy can be in the form of geographic atrophy involving the foveal center itself. Hemeralopia and bullseye maculopathy in patients with cone or cone rod dystrophy are important to remember. Perimetry typically shows a central scotoma, and fundus autofluorescence shows hypoautofluorescence in the foveal region surrounded by a ring of hyperautofluorescence. OCT shows thinning or atrophy of the outer retinal layer of photoreceptors in the central region of the macula, but this layer is preserved more peripherally. Later in the disease process, cone rod dystrophy patients but not cone dystrophy patients also develop progressive nyctalopia, bone spicule pigmentation in the retinal periphery as seen here in this clinical photograph, vascular attenuation and optic disc pallor, and constriction of peripheral fields. Both cone dystrophy and cone rod dystrophy patients show severely reduced and delayed flicker response, which is a cone response on ERG as seen here in this diagram, and the response to pattern ERG, which picks up response from the macula, is also profoundly abnormal in these patients. So if we compare the flicker response of cones between a normal individual, a patient with rod cone dystrophy, and a patient with cone rod dystrophy, we find that The response is moderately reduced and delayed in rod cone dystrophy, but is severely reduced and delayed in cone rod dystrophy. Cone rod dystrophy patients but not cone dystrophy patients also show abnormalities in rod response as shown by this tracing to a dark adapted bright flash stimulus, but the rod response is less severely affected than the cone response to light adapted bright flash stimulus and the cone response to flickered stimulus in patients with cone rod dystrophy, which is just the reverse of the response from the eyes of patients with rod cone dystrophy, and this is important to remember. Inverse retinitis pigmentosa is not a rod cone dystrophy but is a rare variant of cone rod dystrophy. These patients show central scotoma which occurs early and gradually but relentlessly progresses towards the periphery till near total loss of vision. Pigment spicules are more common in the central retina as seen here in these two photographs, and being a cone rod dystrophy, cone ERG responses are more affected than rod responses. Then there is an entity called cone dystrophy with supernormal rod ERG, which is one of the three rare entities with a pathognomonic ERG. We have discussed these entities in the session on electroretinography. Cone dystrophy with supernormal rod ERG is an autosomal recessive disorder, and being a cone dystrophy, patients present with severely reduced visual acuity and colored vision and photophobia. Being a cone dystrophy, ERG shows delayed and reduced ALA responses as seen by these two tracings. The rod response to dark adapted very dim flash stimulus is delayed and reduced, but the rod response to dark adapted dim flash and dark adapted bright flash stimuli show a disproportionate increase in amplitude of the B wave, and this is pathognomonic of this entity. Leber congenital amaurosis is a group of disorders with similar clinical and electrophysiological signs rather than being a single entity, and typically without any systemic associations, and is characterized by severe visual impairment and blindness before 1 year of age. 1/3 of patients with Leber congenital amaurosis have no perception of light, and in the remainder, visual acuity is rarely better than 20/400. LCA is caused by mutations in a large number of genes, and mostly they have an autosomal recessive inheritance. CEP290 is the most common gene to be mutated among patients with LCA, and LCA can be caused by mutations in RPE65 gene also, which is of interest because of the availability of gene therapy for patients with mutations in this gene. The two most common clinical features of LCA are nystagmus and eye poking, and eye poking or oculodigital sign as seen here in this clinical photograph creates phosphines for the sensation of visual perception by the patient. Eye poking is not an exclusive clinical feature of LCA but can be found in infants with poor vision from other causes. A large number of posterior segment signs have been described in patients with LCA, and the fundus may appear normal initially in these patients. Among the posterior segment signs described in patients with LCA, retinal vessel attenuation and central chorioretinal atrophy are important. This color photograph shows a patient with LCA having a central chorioretinal atrophy. Other ophthalmic signs which can be found in patients with LCA include keratoconus, cataract, poor pupillary reflex, and high hyperopia. A profoundly abnormal or absent ERG response is characteristic of eyes with LCA, and this is required for diagnosis of this condition. Rarely, LCA patients have been described to have systemic comorbidities such as neurologic dysfunction, and as we have mentioned, several entities can be mistaken as Leber congenital amaurosis such as infantile Refsum and infantile neuronal ceroid lipofuscinosis, which also present with severe visual impairment in infancy but have characteristic systemic manifestations in addition. SECORD or ESORD is defined as occurrence of retinal dystrophy with severe visual impairment after infancy but before 5 years of age, and it is considered to be in a continuum with LCA and includes other IRDs presenting in this age group such as achromatopsia and albinism. And since the onset is after infancy, these patients do not have a history of nystagmus or poor pupillary reflex. Retinitis punctata albescens is a progressive rod cone dystrophy and is an autosomal recessive disorder due to mutation in RLBP1 gene, which encodes cellular retinaldehyde binding protein. It is characterized by progressive nyctalopia, white dots in the posterior pole extending to just outside the arcades, and development of mid-peripheral atrophic patches later in the disease process. Perimetry shows pericentral scotomas which enlarge both peripherally and centrally. Dark adaptation is always abnormal, and ERG is very abnormal, with rod responses being affected more than that of cones. Retinitis punctata albescens is one of the flecked-retina entities presenting with white dots in the fundus. Other flecked-retina entities include primary inherited ocular conditions such as fundus albi punctatus and fundus flabbi maculatus, entities secondary to inherited systemic metabolic disorders such as cystinosis, oxalosis, and Alport syndrome, vitamin A deficiency, and toxicity from drugs such as tamoxifen and canthaxanthin. We'll be discussing about some of these entities in subsequent sessions. Late stages of other IRDs, which are not primarily diffuse retinal dystrophies, can resemble retinitis pigmentosa, such as Sotsby fundus dystrophy, Stargardt disease, and choroideremia. Differential diagnosis of retinitis pigmentosa and allied disorders include a number of acquired conditions which can cause extensive chorioretinal changes, and this group of acquired conditions are collectively known as pseudoretinitis pigmentosa. These include entities which are infective, inflammatory, traumatic, and due to toxicity from drugs. Infectious causes include rubella retinopathy, which usually presents with fine pigment granules in the fundus, but the ERG is normal or only mildly abnormal, which helps in differentiating it from other pigmented retinopathy entities. Other infectious entities which may present with pigmented retinopathy include syphilis, late stages of herpes and toxoplasma retinitis, and diffuse unilateral subacute neuroretinitis. Pigmented retinopathy can occur following trauma, and this is usually unilateral, either sectoral or generalized, and can have bone spicules. Drug toxicity can cause pigmentary alterations in the fundus, such as with thioridazine as seen here in this photograph, and with hydroxychloroquine as seen here in this photograph. Pigmentary changes can also occur following ophthalmic artery occlusion because the retinal pigment epithelium is disrupted following ophthalmic artery occlusion. Autoimmune retinopathies are rare entities which may show pigmentary changes in the fundus along with attenuation of retinal blood vessels and optic disc pallor, and we'll be discussing this group of entities in a subsequent session. And autoimmune retinopathies can be either paraneoplastic or non-paraneoplastic. Pigmented paravenous retinochoroidal atrophy or PPRCA is considered as an acquired response to inflammatory or infectious diseases. In this entity, pigmentary changes are found alongside retinal veins as seen here in this color photograph. ERG is mildly to moderately affected if at all, but EOG or electrooculogram is usually affected, often significantly. Fundus autofluorescence shows hypoautofluorescence along retinal veins in the zones of retinochoroidal atrophy with a surrounding zone or line of hyperautofluorescence. Bare tracks or grouped pigmentation of retina, as seen here in this color photograph, is a benign congenital acquired condition in which we find irregular adjacent round zones of RP hypertrophy, and retinal function and electrophysiology remain normal in this entity. Genetic counseling is an important component of management of inherited retinal disorders, including retinitis pigmentosa and its allied disorders. Prior to genetic counseling, evaluation of family members of proband is required to determine the mode of inheritance, and this involves clinical examination and to some extent molecular genetic analysis for known genetic mutations. This enables prognostication of the disease with regard to probable future functional impairment, such as impairment in the ability to read and of being ambulatory, and periodic visual field testing enables patient to appreciate the rate of decline. So far as risk to future offspring is concerned, autosomal dominant mode of inheritance implies 50% risk for each offspring of becoming affected. Autosomal recessive mode of inheritance implies 25% risk for each offspring of becoming affected and 50% risk for each offspring of being a carrier when both parents are carriers of the mutation, and all offsprings of an affected parent become carriers, and so consanguinity has a major role in autosomal recessive mode of inheritance. X-linked recessive disease mostly affect males, but female carriers can have variable expressivity of the disease because of lionization, which is random inactivation of an X chromosome in female cells. All daughters of an affected male become carriers, and for a female carrier, there is a 50% risk for each daughter of becoming a carrier and 50% risk for each son of becoming affected, and so consanguinity plays a major role in diseases with X-linked recessive mutation also. And for patients with simplex retinitis pigmentosa, the risk of offspring becoming affected is less than 5% in the absence of consanguinity. Rehabilitation services for visually impaired individuals include visual rehabilitation, psychological rehabilitation, and social and/or vocational rehabilitation. Visual rehabilitation can be provided with low vision aids, and refraction and amblyopia therapy are very important for children with inherited retinal disorders. Retinitis pigmentosa patients are more likely to develop visually significant cataract and at an earlier age as compared to normal population. And as we have mentioned, posterior subcapsular cataract is the most common variety of cataract among patients with retinitis pigmentosa, and majority of retinitis pigmentosa patients benefit from cataract surgery in terms of visual acuity, and preoperative estimation of postoperative visual acuity gain is recommended before cataract surgery. However, peripheral visual field defects and rate of disease progression are not affected by cataract surgery, and postoperative incidence of posterior capsular opacification, anterior capsule contracture, and decentration of intraocular lens are higher in retinitis pigmentosa patients as compared to otherwise normal eyes, and cataract surgery can induce or worsen pre-existing cystoid macular edema in eyes with retinitis pigmentosa. Carbonic anhydrase inhibitors are the mainstay of therapy for macular edema in eyes with retinitis pigmentosa, and this is important to remember. Treatment is usually started with topical dorzolamide, and improvement may take months to occur. Oral acetazolamide is administered if response to topical dorzolamide is inadequate, and methazolamide, which has less side effects as compared to acetazolamide, has been found to be less effective for this indication. Intravitreal triamcinolone and anti-VEGF have shown benefit in some RP patients with refractory CME not responding to carbonic anhydrase inhibitors, but concerns regarding risk of repeated injections, particularly that of steroids, and chronic suppression of VEGF in RPIs exist. Vorticizine neparvovec was the first retinal gene replacement therapy to be approved by FDA. It employs an adeno-associated V2 vector containing human RP65C DNA with additional gene fragments functioning as promoters, enhancers, and translation initiators. This drug is indicated only for patients with biallelic RP65 mutation who are older than 1 year of age and have significant amount of residual viable retinal cells. The protein produced by the normal RP65 gene acts as retinoid isomerohydrolase and is found in RP cells, and it has been estimated that mutation of RP65 gene accounts for 2% of all recessive retinitis pigmentosa and 8% of Leber congenital amaurosis. The phase 3 trial of this drug found that all treated patients had significant improvement in night vision as estimated with multiluminance mobility test, and also significant improvement in Goldman visual fields and full field light sensitivity testing threshold. In multiluminance mobility test, the ability of the patient to move in a standardized environment with variable illumination is assessed, and in full field light sensitivity testing threshold, the intensity of threshold full field stimulus is assessed. Administration of this drug involves performing vitrectomy and introducing the drug into the macular subretinal space through a retinotomy. Treatment at an earlier age is recommended, but risks of vitrectomy and retinotomy in infancy should be considered, and there are several other candidate genes which are undergoing trials. Significant inflammation can occur following gene therapy, and this may manifest as anterior uveitis, vitritis, posterior uveitis, and there is significant concern regarding the potential of this inflammatory entity causing damage to the transduced retinal or RP cells, the RP cells in case of luxturna, as well as the adjacent tissues in an already compromised retina. While gene therapy is indicated when there is significant amount of residual viable retinal cells, electronic prosthesis such as the Argus 2 retinal prosthesis, which has been approved by FDA, is indicated for patients with advanced retinitis pigmentosa with bare to no light perception in both eyes and with evidence of preserved inner retinal function. So retinal prosthesis is meant for patients who have extensive damage to their photoreceptors but still have preserved inner retinal function. The Argus 2 retinal prosthesis consists of a spectacle-mounted video camera connected to a video processing unit which sends signals through an electronic case which is attached to a scleral band to an array which is fixed to the epiretinal surface with retinal tags, and this array sends signals to the inner retinal cells. The retinal prosthesis is implanted in only one eye, the overseeing eye, and in clinical trials it has been found that post-implantation all patients could perceive light, did better on quality of life analysis, and 33% had a visual acuity of 20 by 1600 or better. Other therapies for patients with retinitis pigmentosa and allied disorders include tinted glasses for outdoors, and this is particularly so for patients with rhodopsin mutation having predominant involvement of the inferior retina, and for patients with cone and cone rod dystrophies who experience photophobia in bright environment. Laser photocoagulation for coats like retinopathy, enzyme replacement therapy for late infantile onset NCL, dietary phytanic acid restriction for Refsum disease, and vitamin A supplementation for A beta lipoproteinemia. Therapies undergoing trial include cell-based therapy, in which stem cells are differentiated to retinal photoreceptor-like NRP cells and then are introduced subretinally, and modifying expression of molecules and using drugs to inhibit apoptosis. Unproven treatments with uncertain benefits in patients with retinitis pigmentosa or allied disorders include vitamin A, docosahexaenoic acid, lutein supplementation, and avoiding vitamin E. To recap the salient points, retinitis pigmentosa or RP describes a set of inherited progressive retinal disorder which diffusely affect the entire retina and damage the rods initially followed by the cones, and so are known as rod-cone dystrophy. RP can be typical when it is not associated with any other extraocular manifestations, or syndromic when RP is part of a characteristic syndrome. Most typical RP patients are simplex RP with no known or detected affected family member, and they constitute 40% of all RP patients, followed by autosomal dominant RP, which has a later onset with less severe signs and symptoms and constitute 25% of all RP patients, autosomal recessive RP, which constitute another 25% of all RP cases, followed by X-linked RP, which constitute only 10% of all RP patients but have earlier onset and severe signs and symptoms. The hallmark symptoms of RP include nyctalopia or night blindness and peripheral constriction of visual fields. Central visual acuity and color vision are affected later in the disease process. The hallmark triad of signs of typical RP are bone spicule intraretinal pigmentation, arteriolar attenuation, and waxy pallor of optic disc. RP granularity and atrophy are also characteristic findings of retinitis pigmentosa. Additional ocular signs include cystoid macular edema, epiretinal membrane, coats like retinopathy, posterior subcapsular cataract, keratoconus, high myopia, and astigmatism. Female carriers of X-linked RP have variable but definite involvement with irregular and asymmetric pigmentary changes in either eye, retinal sheen, and ERG abnormalities. In early stage RP, rod responses are affected more severely than cone responses on ERG, and on perimetry, scotomas are found between 30 and 50 degrees from fixation, and these scotomas gradually enlarge, deepen and coalesce to form a ring scotoma, leaving a central island and a peripheral zone intact. In advanced stage of RP, the ERG responses are extinguished, and on perimetry, the peripheral zone is lost prior to the central zone. HD-OCT shows thinning or loss of the outer layer of photoreceptors surrounding the central zone, but the photoreceptor layer within the central zone is less affected. Fundus autofluorescence shows hypoautofluorescence in the region of RP loss and pigmentation, which is separated from the foveal area by a ring of hyperautofluorescence. Fluorescent angiography can show RP defects, diffuse leakage from the outer blood-retina barrier, but usually does not show the typical pooling pattern of CME in RP eyes with CME. Dark adaptometry shows elevated rod and cone thresholds and a prolonged dark adaptation. In addition to the classic pattern of RP, with RPE changes and pigmentation mostly outside the arcades in all quadrants of the retina, other patterns of retinal involvement include RP sine pigmento, in which bone spicule pigments are not found, and RP sine pigmento is considered to be an early stage of RP. Pericentral RP, in which RPE changes and pigmentation occur mostly within the arcades, and sectoral RP, in which only one or two quadrants of the fundus are affected, usually symmetrically in either eye. Syndromic RP are entities which are progressive diffuse rod cone dystrophies associated with a characteristic syndrome and include ciliopathies such as Usher and Bardet-Biedl syndrome, metabolic disorders such as neuronal ceroid lipofuscinosis, Refsum disease and A-beta lipoproteinemia, and mitochondrial disorders such as Kearns-Sayre syndrome. Usher syndrome is autosomal recessive in nature and is both the most common type of syndromic RP and the most common cause of combined deafness and blindness. Retinopathy of Usher syndrome is indistinguishable from typical RP. Bardet-Biedl syndrome, which is mostly autosomal recessive in nature, is characterized by atrophic maculopathy with pigmented retinopathy, post-axial polydactyly, truncal obesity, hypogenitalism and hypogonadism, and renal and mental abnormalities. Cone rod dystrophy is an inherited diffuse progressive retinal disorder in which cones are affected earlier than rods. All inheritance patterns have been described among patients with cone rod dystrophy. Patients complain of hemeralopia, photophobia, and loss of visual acuity and color vision early on in the disease, and develop nyctalopia and constriction of peripheral visual fields later in the disease. Fundus examination shows macular atrophy, often in the form of bullseye maculopathy and temporal optic disc pallor early in the disease, and later in the disease, pigmentary changes resembling typical RP occur in the retinal periphery. Perimetry shows central scotoma early in the disease with peripheral visual field loss later in the disease. ERG shows more severe reduction of cone responses as compared to rod responses. HD-OCT shows thinning or loss of outer photoreceptor layer more severely within the foveal region than more peripherally. Fundus autofluorescence shows a region of central hypoautofluorescence in the foveal region with a surrounding ring of hyperautofluorescence. Cone dystrophy patients do not show the symptoms and signs related to loss of rod photoreceptors, which occurs in the later stages of cone rod dystrophy. Leber congenital amaurosis, or LCA, is a group of disorders with similar clinical and electrophysiological signs characterized by severe impairment of vision from infancy, typically without any other comorbidity. It is an inherited disorder, usually with autosomal recessive mode of inheritance. Affected infants and children typically show nystagmus, ocular digital sign, and photophobia. Examination of fundus can be normal initially or may show a wide variety of findings, including macular atrophy, attenuation of retinal blood vessels, pigmented retinopathy, and optic disc pallor. ERG is characteristically severely attenuated or undetectable, and this finding is required for diagnosis of LCA. Other ocular associations of LCA include hyperopia, keratoconus, poor pupillary reflex, and cataract. Differential diagnosis of pigmented retinopathy include acquired disorders such as infectious retinopathies, which include rubella, syphilis, and diffuse unilateral subacute neuroretinitis, autoimmune retinopathies, trauma, toxicity to drugs such as thioridazine, chlorpromazine, and hydroxychloroquine following ophthalmic artery occlusion, pigmented paravenous retinochoroidal atrophy, and group pigmentation of retina. Late stages of inherited disorders such as Sorsby-Stargardt's and choroideremia, which are not primarily diffuse retinal disorders, can resemble pigmented retinopathy of retinitis pigmentosa. Management of RP and allied disorders include genetic counseling and visual, social, psychological, and vocational rehabilitation. Tinted glasses is recommended for RP patients with rhodopsin mutation and for cone rod and cone dystrophy patients. Cataract surgery is beneficial for most patients with retinitis pigmentosa. Cystoid macular edema associated with RP is treated primarily with topical dorzolamide or oral acetazolamide. Gene therapy with voretigen neparvovec is indicated for patients with biallelic RPE65 gene mutation with residual viable retinal function. Electronic prosthesis or artificial retina is indicated for patients with advanced retinitis pigmentosa with minimal or no light perception. Dietary phytanic acid restriction is required for patients with Refsum disease, and cochlear implantation is indicated for patients with Usher syndrome. Laser photocoagulation is used to treat retinal telangiectasia of Coats-like retinopathy, but vitamin A, lutein, and docosahexaenoic acid have not been proven to be useful in most studies of RP patients. Thank you for listening.